Hi, welcome to K-Medicine. This video is a continuation of the previous one in which we studied the introduction to placental abruption, its pathology, types, risk factors, and diagnosis. In this lecture, we will talk about differential diagnosis of placental abruption, its investigations and management, along with some complications. So without any delay, let's get straight into it. When a pregnant woman presents with pervaginal bleed and abdominal pain in obstetric emergency, what are the differentials that you should think of? Number 1 is placenta previa. Placenta previa presents with bleeding but usually without pain. So that is one key point to differentiate it from abruption. Second, vasa previa. Vasa previa is the rupture of fetal vessels after the membrane rupture. There would be 3 signs for it. Number 1, rupture of membranes. Number 2, PV bleed. Number 3, severe fetal distress. Third differential is uterine rupture. If you'll dig in the history of such a patient, you can find a recent cesarean section or a gynecological operation like myomectomy. Fourthly, rule out other local causes of antepartum hemorrhage. These can be quite common, like fibroids, or polys, or cervical causes like ectropion or vaginal tears or lacerations. Okay, so what are the investigations that you will do in this case? As it has been said that it is a clinical diagnosis, but still some investigations are required to assess the fetal and maternal health. First of all, after you have assessed the patient through history and general examination, send all the baselines. It usually includes CBC, serum RFT and LFT, prothrombin time and partial thromboplastin time, and blood group sampling. 2. Along with regular maternal monitoring of BP, pulse, temperature, and respiratory rate. We do regular rounds of CTG to assess the fetal well-being. Third is the ultrasound. Ultrasound is usually the only radiological investigation that we do. We aim to rule out other causes like placenta previa or any other abnormalities of uterus. In placental abruption, a retroplacental hematoma may be seen. This is most commonly observed with marginal type. Other modalities like CT and MRI are also diagnostic, but we don't usually do it in routine practice. Here I would like to show you an ultrasound of placental abruption. The area with green marker is placenta and the one with red marker shows a clot. We will study about interpretations of ultrasound in gynae and obs in a video soon. Coming to the most important part, the management. First thing is the maternal resuscitation. Regularly monitor the vitals. Secure 2 IV lines with large bore cannulas to replace the blood loss. Inform the relatives and blood bank about the blood transfusion, and arrange anti-D immunoglobulins if required. After this, you have to plan what to do with the patient. A delivery, cesarean or vaginal, or conservative management. This actually depends on fetal and maternal well-being, the amount of abruption, and the age of gestation. It is entirely patient-dependent. The decision depends on a lot of factors. One scenario is when there is significant fetal and maternal, especially maternal compromise, and you cannot delay any further. In that case, we do emergency delivery, preferably by C-section because of maternal exhaustion, regardless of the age of gestation. Second scenario is when the lady presents at term, and you assess that she can deliver normally, means there is no significant maternal compromise. In that case, you can induce labor to prevent further bleeding. Third is when there is only partial detachment and the bleeding is mild and there is no significant maternal or fetal danger after regular monitoring. You go for conservative management. This one includes, number 1, give intramuscular corticosteroids for fetal lung maturity. Number 2, anti-D injection within 72 hours of bleeding in Rh-negative mothers. Number 3, correct anemia. And finally, plan the delivery. Coming to our last section for today, complications. These can be maternal and fetal. Fetal complications include distress or death. Maternal ones include uterine tetany or uterine apoplexy. This is very rare. In this, the blood seeps into myometrium and gives it a bluish hue. It is also called cuvulaire uterus. Often happens with chronic abruptions. I will show you a picture here. As you can see, how the blood seeps through the rent and goes into myometrium. Coagulopathies are sometimes common with it. Platelet count is decreased and APTT increased. DIC and maternal shock are obviously fatal complications. Thanks for watching this video. If you like this video, please hit the like button and subscribe to our channel.